Assalamualaikum. My name is Nurin Jazlina binti Nemase and my matrix number is 071150. And my partner,
My name is Nur Iman binti Khalid, matric number 071497.
and we will be presenting about image critiquing on sacrum and coccyx AP projections. So on my part, I'll be talking about the sacrum AP projection and I'll be starting off by talking about technical factors. So for KVP, we usually use the range for 70 to 80 and 15 to 20 for MAS, and the SID should be 100. And the film size of the cassette is usually we use 10 to 12 inches. So moving on to the next part, which is patient positioning of sacrum AP view. The patient, you have to make sure they empty their bladder and bowels so it doesn't obscure the radiograph when we process it. After patient has lied down on the table in a supine position and legs extended fully, angle the tube 15 degrees, cephalate, and the centering point for sacrum AP view is 2 inches inferior from the ACES. In a normal sacrum AP radiograph, the anatomy that should be demonstrated in the radiograph should consist of 5th lumbar vertebrae, 1st till 5th of the sacral segments, 1st coccygeal vertebrae, symphysis pubis and sacroiliac joints should be included in the collimator field. We will be talking about what is a normal radiograph of a sacrum AP projection and an abnormal sacrum AP projection. In this normal radiograph, there is no evidence of rotation because the ischial spine are equally demonstrated and is superimposed with the pelvic brim. And the median sacral crest and the coccyx are aligned with the symphysis pubis. In a normal radiograph of sacrum AP view, there's 3 indications of angulation, which is the sacral foramina demonstrate equal spacing, coccyx and the sacrum is not superimposed with the symphysis pubis. Now moving forward to alignment of the part of placement. Alignment, there is 3 things that you should know, which is X-ray tube to patient, X-ray tube to IR, and IR to the patient. So in this radiograph, patient and X-ray tube, we cannot determine it because there is no forward border of the collimations, and that says the same with X-ray tube to IR. But one thing that we can identify, which is IR to patient, which we will draw an X there and see where it lands. And it looks like it lands at the centering point, which is at the S3. So for collimation, there's 3 that should be covered, which is superior border, lateral border, and inferior border. For sacrum AP view, the superior border should include L5. Lateral border should include until ilium. The inferior border should include symphysis pubis. For the exposure of normal AP sacrum projections, I would say this radiograph is adequate because for the contrast, thin structure, which is bony cortical outline of sacral foramina and bony cortical outline for body of sacrum is visible and also can be set with density of thin structure, which is bony torticolor pattern of sacral foramina, and thick structure of bony torticolor pattern of body of sacrum is also visible. Next on the placement is M, which is marker. In this radiograph, there is a visibility of marker in this radiograph and it's not obscuring any anatomy that is needed in this radiograph. Next is A, which is aesthetic. The film size that was used is 10 to 12 inches. It was used in lengthwise and there is no evidence of motion. Last but not least, which is N, there is no name that consists of the patient name, the ID number, the institution name, and the date of the radiograph that was taken. So for my conclusion of normal projection, I would reject this radiograph because there is no identification of patient. Moving on to the abnormal radiograph for sacrum AP view. In this radiograph, I would say there is evidence of rotation, more specifically on the left side, because ischial spine should be superimposed with the pelvic brim. But in this radiograph, you can see it on the left side, and it's not superimposed with the pelvic brim. And the median sacral crest and coccyx are not aligned with the symphysis pubis and rotated on the right side. In this radiograph, I would say there is no issue of the angulation because the coccyx and the sacrum is not superimposed with the symphysis pubis, but there is evidence of gas, bowel gas. On to the alignment for X-ray tube and patient and X-ray tube to IR. I would say it's still the same as before, which is cannot be determined because there is no evidence of forward border of collimation. But with IR and patient, it's not aligned. Moving on to collimation of abnormal projections of sacrum epi view, I would say that this collimation field is not quite up to par because the lateral border is there with ilium is still in it and symphysis pubis for the inferior border, but you can't see the superior border of this collimation, which is the fifth lumbar vertebrae. Next, the exposure for abnormal projections of episacrum. I would say this projection is inadequate because for the contrast thin structure cannot be seen, which is bony cortical outline of circumforamina, but the bony cortical outline of body of sacrum is visible, which is a thick structure. Density of bony tubercular pattern of sacroforamina and also thick structure is this bony tubercular pattern of body of sacrum cannot be visible, cannot be seen. Next on the placement is M, which is marker. In this radiograph, there is a visibility of marker in this radiograph, which is right, and the placement of the marker is not obscuring any anatomy that is needed in this radiograph. Next is A, which is aesthetic. The film size that was used is 10 to 12 inches, was used in lengthwise. Last but not least, which is N, there is no name that consists of the patient name, the ID number of the patient, the institution name, and the date of the radiograph that was taken. In conclusion, for abnormal projection of episacrum view, I would reject this radiograph because there is no identification of patient. And secondly, I would say because the exposure is too bright.
So now we're going to continue with epi-coccyx projection. For the first one, we're going to discuss about the technical factor that we use for this examination, which is the KVP we use is 75 to 80 KVP. For MAS, we use 15 to 20 MAS, and for the SID, we use 100 centimeter SID. For patient positioning, first we're going to prepare the patient's bowel before the examination and then position the patient on the table in epi-supine position, which the leg fully extend, and then center the shoulder and ASIS equidistant to the table to align the MCP parallel to the IR. Here we have two radiographs, which is the first one is the normal radiograph and second one is abnormal radiograph. So now we're going to take a look for the first radiograph. Here we can see the anatomical demonstrated, which is the first one is sacrum, sacroiliac joint, coccyx, superior pubic rami, inferior pubic rami, symphysis pubis, obturator foramen, femoral head, And the last one, we have the pelvic brim. In this radiograph, we can see there is no positioning error evident by the coccyx is free from superimposition of pubic rami. Lateral margin of coccyx is equidistant from the pelvic brim on the both sides, indicate patient has no rotate, and the coccyx is aligned with the symphysis pubis. For alignment between X-ray tube and patient cannot be determined because there is no evidence of four-collimation in the radiograph. Same to the alignment between X-ray tube and the IR also cannot be determined because there is no evidence of four-collimation in the radiograph. But for the alignment between patient and IR is correct because the distance from the edge of film is equal to the center of structure. A good collimation for epicoccyx examination is at the superior border include fifth sacrum vertebra, inferior border include symphysis pubis, and lateral border include the pelvic brim. This radiograph show an adequate collimation. The center ray for this radiograph is at the level of 2 inch superior to symphysis pubis. The KVP is adequate because the bony cuticle outline of the thick structure, which is the coccyx vertebra, can be seen. Also, the thin structure, which is the bony cuticle outline of transverse process, also can be seen. The MAS is adequate because the bony tubercular pattern of thick structure, which is the coccyx vertebra, can be seen. Also, the bony tubercular pattern of thin structure, which is transverse process, can be seen. There is the marker in the radiograph, which is the R, indicate the right side of pelvic area. The marker are not superimposed with the important structure. The film size that we use for this examination is 24 times to 30 cm and the film orientation is the lengthwise. There is no motion evident by the clear demonstration of coccyx region. In this radiograph, the name of patient, the registration number, patient ID, date and hospital name are not available. If it available, it should be located at the lower part of the radiograph. In conclusion, I reject this radiograph because there is no patient information in the radiograph. And now we're going to continue with the second radiograph, which is abnormal radiograph. In this radiograph, we can see there is the positioning error evident by the lateral margin of coccyx are greater in the right side, indicate patient head rotate to the right side. And also the coccyx are not aligned with the symphysis pubis. To improve this positioning error, we need to slightly rotate the patient to the left side until MSP perpendicular to the IR. For the alignment between X-ray tube and the IR cannot be determined because there is no evidence of four-collimation in the radiograph. Same to the alignment between X-ray tube and the IR also cannot be determined because there is no evidence of four-collimation in the radiograph. The alignment between IR and patient is incorrect because the distance from the edge of film to the center of structure is unequal. A good collimation for epicoccyx examination is at the superior border include fifth sacrum vertebra, inferior border include symphysis pubis, and lateral border include the pelvic brim. This radiograph show an adequate collimation. The center ray for this radiograph is at the level of 2 inch superior to symphysis pubis. The KVP is inadequate because the bony cuticle outline of thick structure, which is coccyx vertebra, cannot be seen. Also, the bony cuticle outline of thin structure, which is transverse process, cannot be seen. The MAS is inadequate because the bony tubercular pattern of thick structure, which is coccyx vertebra, cannot be seen. Also, the bony tubercular pattern of thin structure, which is transverse process, cannot be seen. There is the marker in the radiograph, which is the R, indicate the right side of pelvic area. The marker are not superimposed with the important structure. The film size that we use for this examination is 24 times to 30 cm and the film orientation is the lengthwise. There is no motion evident by the clear demonstration of coccyx region. In this radiograph, the name of patient, the registration number, patient ID, date and hospital name are not available. In conclusion, I reject this image because there is no patient information in the radiograph. Also, the radiograph is too bright, indicate the underexposed and under penetration. I think that's all from us. Thank you very much and enjoy the video.